Welcome to our symposium on uncovering effective CBT components in preventing and treating depression among youth. I am Denise Bodde. I'm assistant professor at Utrecht University. I'm also a clinical psychologist at Utrecht. And well, this is a bit strange, of course, because of the corona. We can't not meet in person, so we're very sorry for that. So we're going to try to make this workshop as as interactive as possible, but this is pre-recorded, so we hope we can try to engage you in this symposium. So maybe you can grab a pen and paper because we're going to ask you some questions about your own clinical work about CBT in depressed youth. So grab a pen and a paper and let's get started. Well, first, I would like to share that our data from this presentation are part of a national collaboration of universities, of mental health care facilities, and it was subsidized by the Dutch Organization for Health and Research and Development in the Netherlands. And let's start with the topic. The topic is CBT in depressed adolescents. And as you can see, this is a selection of protocols or manuals for the prevention and treatment of depression among adolescents. And they're almost all based on CBT. And CBT, as you know, has proven to be effective in depression for adolescents. And all these protocols have kind of the same content. They have the same target group. So they have all these similarities. And the goal of our consortium was basically to give some directions onto which of these protocols do we have to choose. When you're a clinician and you're working with depressed adolescents, there's so many protocols and manuals. Which one is the best? Which one is the most appropriate for your client? So that's the main goal we had as a consortium. So we know that CBT is effective, but we also know that it's not 100% effective. From a review, we know that about 50% of the adolescents are free of their depressive disorder after CBT. So that's 1 in 2. So 1 is also still has their depressive disorder. And also another review by Klein also shows that the effect size is medium, so it's not large. So we want to basically increase the effectiveness of CBT. And as I already said, it's pretty difficult for a clinician or professional to choose from the available interventions. Which one do you choose? Based on what? Based on evidence, evidence-based, or do you look at specific content? So it's really difficult to choose your protocol. And also, in CBT, we don't know now what works. So we don't have any knowledge on what specific part of CBT works. Is it the cognitive restructuring that works, or is it more the activation part that works? So we don't really know, because all the interventions that are investigated are mostly packages of CBT. So they all include cognitive restructuring, activation, problem solving, relaxation. And we don't know, we cannot pinpoint which component is effective, which ingredient makes the better outcomes. So what we basically wanted to do in this research with this consortium is to identify these CBT components and see if they result in better outcomes. So which component is especially helpful for depressed youth? And if you look at what is commonly used in CBT for depressed adolescents, you see that there's psychoeducation that's been given, so information about the depression, information about CBT. Usually we provide some cognitive restructuring, we identify thoughts, we challenge thoughts, and maybe we give some positive thoughts to be more helpful. We use self-monitoring, so the depressed adolescent monitors his depressed symptoms each day. We do some activation to engage the adolescent to be more activated and do some more pleasurable activities. We do some relaxation exercises. Problem solving is usually a component that involves in CBT. Some do some social skills training so that the adolescents learns more to engage in social activities. And some also use some relapse prevention to prevent recurrence. So these are the basic components that we see mostly in these CBT protocols. And what we wanted to ask you is if you could think about which component do you use? So write down which of these components do you recognize and which components do you use with depressed adolescents? So write that down for a moment. So you can also write down which component that you use most frequently. So maybe you use cognitive restructuring the most, or maybe you use activation the most. So write down the component that you use most frequently. And also write down which component that you use least frequently. So maybe you don't use relapse prevention, or maybe you don't use relaxation skills. So write those down as well. Okay. So in this workshop, we will give you two parts of information. And first, the first part is more information about the taxonomy tool that we developed and that we use to code different kinds of manuals for depressed adolescent CBT manuals. And the second part is by my colleague, Marieke van der Heuvel, and she will show you the effects of the microtrial, also focusing on these CBT components. So let's have a look at the taxonomy. We developed the taxonomy to rate the CBT manuals that exist for children and adolescents with depression. And in this taxonomy, we focus on three different areas. So the first is contextual factors, the second is structural factors, and the third is that we looked at CBT components. And what we basically did is we used this taxonomy to rate or code national and international CBT manuals. So why do we need this information about these core components? Well, if we look at research on evidence-based protocols, we usually see that there's poor implementation in practice. So people do use some kind of protocols, but they use it in a different way, or they use just some elements out of a manual or some protocol. So they make some changes. So they don't use the entire protocol. And we also see that there's an enormous overlap in components that are in those different kinds of protocols. So because of this overlap, maybe we could choose just one basic protocol. So a focus on these core components might enable us as practitioners and researchers to figure out what works for whom, when, how, and why. And we wanted to investigate if we could select some common components to see if they are beneficial in outcomes. So if we have these specific components, we can also might select some specific components for specific clients so we could make a more personalized intervention. And to get some idea of what we did, it has been done in a different way, for example, by Michi in 2013, and she looked at behavioral change techniques, and they also coded different kinds of protocols and to see which kind of behavior change techniques were used. Shorpita in 2005 also coded manuals based on CBT, on randomized controlled trials that investigated CBTs. and they call that practice elements. And these practice elements are basically kind of clinical strategies. And they coded 58 of these practice elements. And for depression, you see the results here, that they found that the most common practices for depressed adolescents, CBT practices, were cognitive, psychoeducation, relapse prevention, activity scheduling, problem solving, and self-monitoring. They based this on 24 depression CBT protocols that were used in evidence-based research, so in randomized controlled trials. So the main part of protocols had cognitive, psychoeducation, relapse prevention, activity, and problem solving. So that's what they found. And what we did, we developed this taxonomy to look basically at, it was more elaborate than that. So we didn't look at these practice elements alone, but we also look at contextual factors. So for example, what's the goal of this intervention? Is it prevention? Is it intervention? We looked at the setting of the intervention. Is it delivered at home, in a clinic, in school? We looked at the target group. Is it directed at the child, or is it directed at the parents, or is it directed at both? We look at the age. Is it appropriate for children, so till the age of 12, or more for adolescents, or maybe for the parents? We looked at the severity of the depression complaints, and we also looked at structural characteristics. So those are characteristics that are about the structural part of the intervention. So for example, the number of sessions, how many sessions are there in this manual, and what's the time per session that was described in this manual? What's the frequency that this treatment has been given? What's the sequence? Is it 1, 2, 3, or can you mix sessions? What's the form? Is it face-to-face? Is it online? Is it blended, online and face-to-face? Or is it a group format? What kind of format is it? We also look at therapist characteristics that were advised in the manual, and we also looked at the scientific evidence of the manual. And the third thing that we did is we looked specifically which of these CBT components can we identify in these manuals. So we looked at these common CBT components, and we looked if we could identify them in these manuals. So how many sessions does this manual attend to psychoeducation? How many sessions can we find cognitive restructuring in this manual? Self-monitoring, activation, relaxation, problem solving, social skills, and also relapse prevention. So how many of these components can we identify in this manual? So to give you an example of what we specifically investigated, so per module we looked at, so what's the name? Is it activation? What's the definition? What are the steps in this module that should be followed? Who's the recipient? Is it the child? Is it the parent? What's the modality? Is it that we practice it, or is it modeled by the therapist, or how is it given? What's the mode of delivery? So what's the way that the therapist gives the information to the child? Is it face-to-face? Is it blended? But also the dosage. So how much has it been used in this manual? So to give you an example, this is the activation, the module activation as an example. So the name is activation, the definition, to engage the child or the adolescent in more pleasurable activities. Well, the steps that we identified in the activation process is, first, you explain to the child that there's an association between behavior and mood. Then you develop an activity list with the child. You let the child monitor their activities, so pleasurable activities. You examine the activity list, so you make sure that it's really the pleasurable activities that they're that they're doing, so it's not something that they have to do or that they don't enjoy doing. Then you develop a new activity plan, so you really set goals for the child. So for example, each day you have to do 2 pleasurable activities, and then at last you evaluate this with the client. So you look if there's an association between the activities and the mood, and if it's going well, or maybe something has to change. The recipient is the child in this case. The modality in this case, in this manual, was it's been done with exercises during the therapy, but also with homework, so at home. And the mode of delivery was face-to-face. And the dosage was 6 sessions, and in each session, 15 minutes were spent on activation. So the design for this research was that we basically did an inventarization of all national and international CBT depression interventions. So there were like 50 that we could identify. And then we checked whether they would fit our criteria. So we excluded some protocols because, for example, they had a different focus they focused on other psychopathology, for example, anxiety, or they didn't involve CBT, but another kind of method. 5 were excluded because they were kind of too old and so nobody ever used them anymore. And 7 were, we weren't able to obtain a manual. So eventually we ended up with 23 manuals. 11 were Dutch and 12 were international. Most were American based CBT protocols. And what we did is that we coded all these manuals and checked what we could find of these structural contextual factors and these components in those manuals. So the results were as follows. If we look at the contextual factors, we found that most of these protocols are manualized. So they have this protocol, and 70% also had this workbook for the client. So this is very easy. If you have this information for the client, then it's really, it's a good way to work with a client. The goal was mainly as an intervention, so as a treatment, and 39% was indicated prevention, so children with subclinical levels of depression. 9% was universal prevention, so that's for everyone. And what we found is that there was no specific protocol for relapse prevention, so that was kind of surprising. The setting, 30% was given in schools, and 26% was given in mental health care facilities, and 30% was given at home. Some other contextual characteristics that we found in these manuals is that the target group was mostly the child, so 70% of these manuals were focused on the child, 22% were focused on child and parents, 9% on the parents. And if you look at age, most of these manuals were focused on adolescents, so that's 83%. And there was little for the age under 12, so there was 17% were directed at both children and adolescents, but none specifically for the younger children. Severity, most protocols were focused on subclinical depressive symptoms, so 44%, and only 22% was directed at a real clinical diagnosis. So that's also very surprising. 26% were aimed at both prevention and intervention, so both at subclinical and clinical depressive symptoms. If we look at structural characteristics, we see that Most of these manuals had session ranging from 4 to 18, so 4 to 18 sessions, and the mean of the sessions was 10. So most manuals use around 10 sessions to treat the child. The time of the session ranged from 35 minutes to 120 minutes, and the mean time was around 67 minutes per session. And most of these treatments took around 60 minutes each. The majority was given once a week, so not twice or not more intensive, but just once a week. If we look at more structural characteristics, we see that the sequence was consecutive. So it was like you do first you do session 1, then 2, then 3, then 4, then 5. So you cannot change sessions. It's not flexible. And the form of treatment was mostly face-to-face in a group format. Face-to-face individuals also in 39% of the manuals, the format of choice. 9% of the manuals that we investigated had a blended format, so face-to-face with online content as well. Online and games was about 4% of the manuals that we investigated. So what about these components? We were very interested in these components. What do we see? What can we see in these manuals that's frequently used? Well, cognitive restructuring was used in 100% of all these manuals, so that's used mostly. Followed by self-monitoring in 83% of these manuals. Activation, we identified activation in 78% of the manuals. Problem solving as well, 78%. Psychoeducation was given in 70% of these manuals. Relaxation in 65%, and social skills in 57%. So almost half of the manuals have some kind of social skills training in them. And relapse prevention also only in 50% of the manuals, which is kind of striking because, we know that recurrence rates in depression are very high, up to 70%. So you really want to use some kind of relapse prevention, but only 1 in 2 manuals use relapse prevention in their manual. Go back to that one, because we also found that the most time was spent on self-monitoring and cognitive restructuring. So around 4 sessions were spent on those topics. And if you look at least time, so which component took the least time? Well, activation. Activation was almost always done in about 1 session. So the least time was spent on activation. If we look into more detail in these components, for example, cognitive restructuring, you have these different steps that might be, according to the theory, you should follow these steps. For example, you should start with identifying the negative thoughts. Well, 100% of the manuals describe this step. Then you investigate if there's a relation between the event, thought, feeling, and behavior. Well, 96% of the manuals do this, so that's pretty okay. Then proposing a positive cognition was done in 91% of the manuals, so that's also a pretty high percentage. And challenging these thoughts, so really looking like a detective to pros and cons of a cognition, was done in 83% of the manuals. So cognitive restructuring is pretty well embedded in these manuals. But if you look at activation, there's the percentages is somewhat lower than cognitive restructuring. So 78% of all manuals have some kind of activation. But if you look at, for example, the rationality, so explaining why you do activation, it's been done in 70% of these manuals. So they don't all explain why activation is important. So that's kind of a surprising finding. Also, 65% uses an activation list. So registering what kind of pleasure activities that the client does. So that's also not really a high percentage. Even less manuals use the monitoring of these activities, and also 57% make an activity plan. So they really set a goal for the client to do these activities. So this is cognitive restructuring seems pretty okay, embedded in these manuals, but activation, some steps seem quite underrepresented in these manuals. What about the parents? Well, parents were involved in these manuals for 39%. So less than half of these manuals include some kind of parental involvement. And usually parents are involved with psychoeducation. So they get information about the depression, or they get information about the depression or CBT. So that's 78%. Then contingency management, so rewarding appropriate behavior and neglecting inappropriate behavior. That's in 44% of the manuals, some focus is on that. Then transfer of control, so basically the therapist telling the parents how to help the child with the depressive complaints is done in 44% of these manuals. Then family functioning only in 22%, and in 33% they evaluate the treatment. So parental involvement is done quite less frequent. So to give a sort of recap, the majority of these manuals that we investigated, we focus on cognitive restructuring, on self-monitoring, activation, and problem solving. And the minority focus on relapse prevention and parental involvement. So there should be some more programs that focus on relapse prevention, that focus on parents as well, and also focus on younger children, so under the age of 12, because most of the manuals were directed at adolescents. And maybe there should also be some more protocols for clinical depression, because now they're often focused on subclinical depression. And concerning activation, we see that there's little focus on monitoring of these activities, and also a lot of manuals don't plan activities. So we don't follow all the kind of theoretical rules that should be embedded in activation. And also we only use, these manuals only use activation in one session. So that's pretty, it's not a lot of time that's spent on activation, while it's a pretty important ingredient. So we have all these factors and components, and then what do we do with them? Well, this was the first that we did in the consortium, and then we wanted to see if these factors could influence the effectiveness of CBT. So we did some meta-analysis, individual patient data meta-analysis, and we also did microtrials, and Marieke is going to tell you more about those in a minute. But first I will share with you the results of the meta-regression. And we looked whether these components that we identified in these manuals, if they were associated with treatment outcome. And we investigated 31 studies with over 4,000 participants and 37 CBT studies. And the overall effect size that we found in this meta-regression was 0.48. So that's a medium effect size, which is comparable to earlier studies and reviews and meta-analysis. But concerning these components, we found that there were better outcomes when the manual or the protocol involved behavioral activation. And we also found a better outcome when some kind of challenging of thoughts was applied in the protocol. And last but not least, we also found better outcomes when parents were involved in these manuals. So this is what we found in a meta-analysis, and we also wanted to see if we could do this in a specific research kind of style. So Marike is going to tell you more about the components that we investigate in this taxonomy and how we translate those into a microtrial.
My name is Marieke van den Heuvel, and I work as a PhD student at the Erasmus University in Rotterdam. My PhD is on the differential effectiveness of different CBT components in depression prevention, and also on the differential effectiveness of different sequences of CBT components. To examine this, my colleagues and I conducted a microtrial. A microtrial is a randomized experimental design that investigates the effect of relatively brief and focused manipulations, such as program components or sequencing of components or the dose of components. And this is in contrast to an RCT that examines the effectiveness of complete or full treatment packages. So in a microtrial design, the question is not what is the effectiveness of a full treatment package or a specific program, but what is the effectiveness of a specific program component. Most commonly used CBT components in the current protocols for depression prevention are problem solving, cognitive restructuring, behavioral activation, and relaxation. However, there's hardly empirical evidence for the effectiveness of these components. And yeah, besides, current protocols do not have a fixed sequence of these components, and even within one session, often different components are used. The aim of this study was to gain insight in the relative effectiveness of the CBT components, cognitive restructuring, activation, problem solving, and relaxation. And we also wanted to know whether the sequence of these components is relevant for the effect. So we also examined the differential effectiveness of the sequencing of these components. So in our microtrial, we manipulated the specific components and the sequencing of these components. And in this model, the blue boxes are cognitive restructuring, the red boxes behavioral activation, green is problem solving skills, and orange is relaxation. And we used 4 parallel conditions. And in each condition, each 4 components were provided, but the sequencing of these components differed. So for example, in condition 1, that started with cognitive restructuring, then behavioral activation, then relaxation, and then problem solving. And in the other condition, in the other conditions, there are other sequences. We chose for the 3 most logical sequences, that are the first 3, and the least logical sequence, that is the last one. So the least logical sequence starts with relaxation, and it ends with cognitive restructuring. And that is not very common in clinical practice and in current protocols. So our expectation was that the last sequence would be least effective in preventing depression among adolescents. Each block represents 1 week, and each component, we call them modules, consisted of 3 sessions. So 1 session per week was provided. Assessments were conducted at baseline, T0, at post-test, T4, and at 6 months follow-up, T5. And we also measured after each module, so after module 1, module 2, and module 3. So after 3, 6, and 9 sessions. And between T0 and T1, we could examine the differential effectiveness of the different components. And between T0 and T4 and T5, we could examine the differential effectiveness of the different sequences of components. We recruited adolescents via 11 secondary schools in the Netherlands. And we screened a total of 8,603 adolescents on depressive symptoms using the full version of the Child Depression Inventory. And of those adolescents that were screened, 2009 met the inclusion criteria. And those adolescents were invited for participation. And inclusion criteria were ages between 10 and 20 years old, having a percentile score above 75 on the CDI-2. And exclusion criteria were receiving treatment at the moment for anxiety or depression-related problems and suicidal ideation. A total of 282 adolescents decided to participate in the study, which is 14% of the adolescents that were eligible. These adolescents were stratified by gender and age, and then treatment groups of approximately 5 students were formed. And these treatment groups were randomized as a cluster to one of the 4 conditions. So our sample consisted of 282 adolescents with elevated depressive symptoms, and of them, 21% had a depressive disorder according to the KIDI-sets. So our sample was relatively severe. The mean age was almost 40 years old. Our sample consisted of somewhat more girls than boys. 50% had a high educational level, and most of them had a Dutch ethnicity. And we found out that adolescents were less likely to participate if they had lower levels of depressive symptoms, were older, had a low or moderate education level, or a non-Dutch ethnicity. Here you see a table with selection of the measures we used. And our main outcome, or primary outcome, was depressive symptoms as measured with the CDI-2. And we used both the full and the short version of the CDI-2. We developed an indicated group prevention program ourselves, in close collaboration with a CBT therapist and experts in the field, and also based on the taxonomy as presented by Denise. And we also used current CBT protocols and the match, which is a modular approach developed by John Wise and Bruce Torpeda. For each of the 4 components, we developed one module of 3 sessions, so 12 sessions in total. And the program was provided at school once a week. The training was provided by trained psychologists. We think it might be nice to tell something more about the content of the 4 modules. And then you will also see how the content links to the taxonomy as presented by Denise. In the module Solve, we first provided psychoeducation about problems, 2 ways of coping with problems, namely avoiding or solving, and consequences of using these types of coping. And we teach the adolescents to solve their problems by using 7 steps. And here at the right, you see a scheme that we used to teach them. It's in Dutch, so here you see the translation. The first step was to describe the struggle or the problem. And in the second step, adolescents had to set a goal, something they want to achieve. In the third step, they had to brainstorm about solutions. And we encourage the adolescents to think about in-the-box solutions and out-of-the-box solutions, where in-the-box are more ordinary, normal solutions, what most people would do. And out-of-the-box solutions are more funny or creative solutions. And we, with the out-of-the-box solutions, we stimulate to think differently about their problems, to think about new solutions. The fourth step was to evaluate the solutions by think about the advantages and the disadvantages, but also about the effectiveness. So do I achieve the goal with this solution, and the feasibility. The fifth step was to choose a solution based on the evaluation. 6, they had to create a plan of action, so what they wanted do to apply the solution in their daily life. And the last step was to evaluate the plan and to reward themselves, not only for achieving the goal, but also just for trying to find a solution for the problem. And the last thing in this module was that the adolescents were taught to seek social support as a coping strategy as well. For example, support from their parents or friends. The module Think, that started with psychoeducation about the relationship between thoughts, feelings, behavior, and consequences, both short and long term. And we teach them to challenge negative thoughts and to generate more positive thoughts with 7 steps. Again, in a scheme, which you see at the right. The first step was to identify a negative thought and to schedule the event, the thought, the feelings, the behavior, and the consequences. And in the second step, they had to assess the credibility of the negative thought by choosing a number between 1 to 10, with 1 not credible and 10 very credible. And in the third step, they had to examine evidence for and against the negative thought, with evidence for as evidence that showed why the negative thought is true, and evidence again showed evidence why the negative thought is not true. And in the fourth step, they had to choose the strongest evidence why the negative thought is not true. Based on this evidence, they generated a positive thought by step 5, and again, they scheduled the thought, the feelings, the behavior, and the consequences. Then at step 6, they assessed the credibility of the positive thought. And at step 7, they reassessed the credibility of the negative thought. So in the end, you hope that the credibility of the negative thought has diminished and the credibility of the positive thought is higher than the credibility of the negative thought. Of course, this takes time to practice. The module ACT. In this module, we provided psychoeducation about mood fluctuations and the relationship between mood and activities via the positive spiral and the negative spiral. And we teach adolescents to monitor their daily mood and the activities they engage in via mood monitors at the right and an activity list. And here you see the different activities, for example, watching series or laying on the couch or chilling with friends, going to the city, go shopping. And here you see the different days. And here they filled in what activity they engaged in each day. Then the adolescents examined the link between daily mood and activities in the graph. We called it a combination graph. And in orange, you see the feeling of this particular student. And in the blue, you see the total amount of activities per day. And based on this graph, they adapted their activity list. We encouraged the adolescents to do activities that gave them a happy feeling. So, for example, to remove the activities that were too difficult or didn't give them a happy feeling. And we encourage them to set a goal to increase the pleasant activities. That's the red line. That was the goal for this particular adolescent. And the last step was to evaluate the goal. I have a small exercise for you related to the module ACT. Think about the 2 small activities that make you happy and set them as a goal for today. Activate that happy feeling. So it can be everything. Here at in the red box, you see an activity list. It's again in Dutch. It includes 200 activities that the adolescents like. For example, doing something with my friend, or go swimming, or bake a cake, take a bath, or nice shower, or wash my hair, etc. So that's maybe something you can do as well. Think about 2 small activities and do it today. And the last module is relax. And this module started with psychoeducation about stress. And we teach adolescents 4 types of relaxation exercises. So attention task concentration techniques, breathing techniques, progressive muscle relaxation, and guided imagery. Guided imagery. But let's go back to the research questions, because we wanted to know the differential effectiveness between the differential effectiveness of these different modules components and the differential effectiveness of the different sequences of components. Well, here you see the results in a graph, and we use data to examine these research questions, and we used multi-level mixed modeling. At the y-axis, you see the level of depressive symptoms as measured with the CDI-2, the short version. And at the x-axis, you see the different time points. So at T0 baseline, then the intermediate assessments at T4 post-test and T5 to 6 months follow-up. And in the box below, you see the different conditions. So in blue, it's think, act, relax, and solve, for example. And in red, it's act, think, relax, and solve. So in this graph, you see the development of the depressive symptoms over time for each condition. The effect of the 4 different modules was measured between T0 and T1. And we found out that none of the modules showed a significant decrease in depressive symptoms. And we also found no significant differences between the 4 modules in the effect or the absence of the effect on the depressive symptoms after 3 sessions. The effect of the different sequences was measured between T0 and T4 and T5. And we found out that all different sequences showed a significant decrease in depressive symptoms at post-test and 6 months follow-up relative to baseline. And again, no significant differences were found in effect between the different sequences. Between T0 and T2 and T3, we explored the effects after 6 and 9 sessions. And we found that none of the modules showed a significant decrease of depressive symptoms at these time points, except for condition 1, that is the blue line. The decrease in depressive symptoms in depressive symptoms in condition 1 was already significant at T2, so after 6 sessions. So the adolescents in this condition responded quite rapidly. However, these are within group effects, and again, we found no significant differences between the different conditions. So we found no differences in effect between the 4 modules. And yeah, we also found that 1 module of 3 sessions is not sufficient to reduce the level of depressive symptoms. Our decision making to use 3 sessions per module was quite pragmatic. In depression prevention, the standard dose of CBT is 12 sessions, and we wanted to examine 4 components. So yeah, that resulted in 3 sessions per module per component, but it's relatively arbitrary, and it might be too short to achieve a relevant effect. We also found no differences in effect between the 4 sequences of modules. Relative to baseline, we found significant reductions in depressive symptoms at post-test and 6 months follow-up in all conditions, with at post-test small effect sizes and at 6 months follow-up medium effect sizes. And these effect sizes, the within group effect sizes, are comparable to other Dutch programs, other Dutch indicated prevention programs. This study is the first study that examined the differential effectiveness of different CBT components and different sequences of components. But it also has some limitations. And the first limitation is that we did not include an inactive control group. And therefore, we do not know whether the effect of the 4 modules can be specifically ascribed to the intervention. And lastly, we did not include a long-term follow-up, which make it difficult to make any statements about the effects at the long term. A clinical implication of our microtrial is that the investigated CBT components might be used more flexible regarding the sequencing in indicated prevention for adolescents. And this might be a step to a more modular approach, like the match, for example. We did not find any differences between the components and sequences in effect, but there might be some individual differences or subgroup difference. And therefore, we are examining now moderation effects. And we hope that these analyses provide useful information to tailor intervention more to subgroups or individual needs. At last, we want to ask you to take a moment of self-reflection. You have heard a lot of information in this presentation, in this workshop, and we want to ask you to take some time and think about what you've heard and to reflect on what you do in practice. How do you use the different components, and is there something you heard in this presentation that what you want to adapt as well? So the questions are, do you use CBT components mainly entwined in full CBT protocols, or also more individually, so modular? And do you use these CBT components in the same way or differently as ascribed in this presentation? So do you use all the specific steps in one component as showed in the taxonomy or the different modules? And what are the advantages and disadvantages of using different modules in CBT? And the last question, which information from this presentation would you like to apply in using CBT for depressed adolescents? Oh, we thank you very much for listening and for participating in this workshop. And we hope that you enjoy it and that you can adapt something of this information and what you do in clinical practice with your adolescents. Thank you very much.